that's a lot of what the Better CPR Conversations work is around, is helping both clinicians and the community understand that this isn't a intervention that's necessarily a choice, and it doesn't mean if you say yes you're going to have it you'll survive, and if you say no you won't. This is about recognizing when it adds value and when it doesn't, and if it doesn't, helping people understand there's still a lot of other things we can do on that journey for them that actually may give them a much more I'm saying fulfilling, that's probably too big a term, but a death that might be more as they envisage, rather than a medical intervention happening in those last moments of their life.
Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk about ways to put the human back at the center of care.
Waiting Room Revolution starts right now. All right, welcome back to the Waiting Room Revolution. We are so excited to have two guests from around the world joining us today. We have with us Dr. Tammy Pegg, who is a cardiologist from New Zealand, and Jane Goodwin, who is the National Program Manager for Advanced Care Planning in New Zealand. They are both advocates for advanced care planning, and they work together on the Better CPR project. So we're going to talk about all of that and so much more. Tammy, Jane, welcome to the podcast.
Kia ora.
Hey, Sian, Sammy, thank you very much. Kia ora.
Our pleasure.
Well, I kind of wanted to start at the beginning with both of you. Maybe Tammy first. Was there sort of a story or an experience that really made you want to advocate for changing people's understanding about CPR?
Yeah, there was actually. I was sat in the office when one of our advanced care planning facilitators locally popped into my office and sat down and said, "Hey, I've been asked to do a critical care review of this case, and I just wanted to get your thoughts." And it was a lady who had was in a nursing home and had eaten an egg sandwich and had aspirated and choked on it. And she had a DNA CPR form, and the rest home staff, I think, must have been panicked, very stressed out, didn't know what to do, didn't remove the obstruction, and the lady choked and died. And the advanced care planning facilitator, the amazing Carla Arkless, was saying, how do I support the residential care facility? And I sat down and thought, well, why did they not remove the obstruction? Because CPR's chest compressions and rescue breaths. She says, I know, they didn't seem to understand what it was. I spoke to my colleagues. We live in a shared office, 5 cardiologists, and I started to understand that our collective understanding of cardiopulmonary resuscitation differed, which was hugely shocking for me, because we was in the process of rolling out our national sort of DNA CPR process, what we call shared goals of care in New Zealand. And we had not really contemplated clarifying or defining CPR as part of the project. And I started to get that, that really uneasy feeling when you start to realize, oh my goodness, what have we got going on here?
And DNA CPR stands for Do Not Allow Cardiopulmonary Resuscitation. Is that right?
Do not attempt.
Do not attempt.
Cardiopulmonary. Yep.
Yeah. And Jane, how did you get involved in and so passionate about wanting to promote advanced care planning more broadly, but also connected to the CPR project?
Yeah, my journey with CPR, I come from a nursing background. So I guess my original sort of experiences and what led me to do my master's research was looking or having experiences where patients were coming into some acute facilities, often quite early in their admission trajectory, and something would happen, they would deteriorate, and we would attempt CPR on that person, and then the family would arrive and say, no, this isn't what they wanted. And consistently I was seeing that this was coming often from people that were coming in from aged residential care facilities, rest home settings, and it turned out there had been documentation in that space that hadn't been well communicated to our acute services in that transition and that admission. So that was where I kind of focused my master's research, and as part of my literature review is that I uncovered this wonderful place called advanced care planning, which was relatively early in its evolution at that time. And yeah, decade and a bit later, this is kind of where I've ended up. So the work that I've done in the ACP space, advanced care planning space, has sort of broached local, regional, and national, and have had the pleasure of working alongside Tammy for a lot of that time. And I guess as we've worked through, so the shared goals of care work was some of the work we were leading as a program, and having the opportunity to have Tammy as our clinical lead in that space, coming on board and saying, we may have an issue here, and working through how we could recognise and understand that. So Tammy did some work around surveying to get a real sense of actually what the situation was like. And then that sort of led us to the project we did around better CPR conversations.
Yeah, I just want to know more. I want to know more about what you're up to in your project.
Yeah.
So Tammy, do you want to let them know a little bit more about what the work is and what we found and where we're off to?
So it did start with a survey about 3 years ago, where we did a sort of pop quiz disseminated through social media. And we understood that 97% of health practitioners in New Zealand thought that cardiopulmonary resuscitation was inclusive of all resuscitation measures. So defibrillation medications, and so on. Actually, the New Zealand definition of cardiopulmonary resuscitation aligns with the US and Canada, in that cardiopulmonary resuscitation is defined as chest compressions and rescue breaths as an intermediate step to another maneuver. So and that kind of aligned with our national share goals of care form, in that we have sort of 4 levels of ceilings of care. We run A through to D, and A is curative restorative intent inclusive of CPR. B is curative restorative intent exclusive of CPR. C is treatment aimed at improving symptoms but are non-burdensome, and D is care for the dying person. And so it actually aligns with our shared goals of care form, in that if we make sure that CPR is just viewed as a bridging measure, an intermediate measure towards restoration of circulation, and doesn't exclude intensive care, doesn't exclude dialysis, doesn't exclude anti-choking maneuvers, or even defibrillation for monitored arrhythmia, sort of in my world in the cath lab, then it opens up the opportunity for us to really consider the value and purpose of cardiopulmonary resuscitation, which I think has been forgotten from the original wisdom that was set down now 70 years ago. That's how old these techniques are.
Okay, wait a second. So just so our listeners understand. So what you're
Yes.
saying, that CPR, we should think of it as a bridge.
Yeah.
Bridge to some other intervention that will keep you alive, or it's just a bridge. It's not in and of itself a treatment.
No. Absolutely, that's spot on correct, because chest compressions and rescue breaths manually push blood around the body. That's its only purpose. It's not even as good as your own heartbeat, so it only pushes around 20 to 30% of your circulating volume, your blood around your body, and it provides some emergency blood flow to the brain and major organs, whilst we're trying to figure out the cause of the cardiac arrest. And that's really important, because if the treatment is for your cardiac arrest is complex or hours away, CPR is not an effective procedure. And so it has no value or purpose in that person's trajectory. But also, what's more important is, I think in hospital medicine, we have lost the concept around natural dying as distinct to cardiac arrest. So James Jude, who is the pioneer, the forefather of cardiopulmonary resuscitation, who first reported on the technique in the Journal of the American Medical Association in the early 60s, he defined cardiac arrest as sudden, unexpected cessation of circulation. And of course, what we see in modern hospitals these days is not sudden, unexpected cessation of circulation. It's complex illness that progressively deteriorates despite medical treatment, and then leads to the secondary cessation of the heartbeat. And in that situation, there's no within reach treatment that we can administer that CPR would be a bridge to.
Yeah.
It's so interesting because as you're talking, I'm thinking, oh my goodness, I am positive in our hospitals here that they are given a choice. Okay, let's do your advanced directives or whatever they call the form du jour. Would you like this or this or this or this? And it's offered as a menu, like one of them being, oh,
Smorgasbord. What would you like?
charcuterie board, right? So you can
Yeah.
have chest compressions and rescue breaths, like CPR, but you might not want intubation and meds and this and that, whatever. So that sounds sort of ridiculous to me, right? Because getting just CPR is going to get you nowhere unless it is a sudden, unexpected cessation of heartbeat, which is not what we're seeing typically. Well, especially with our patient population, which are people who are facing progressive life-limiting illness. There's really nothing sudden about it. It's right. So,
Ordinary dying.
so is it weird that people are offering chest compressions and rescue breaths, but they can say no to the rest of it?
I think it's indicative of the creep that's happened with this terminology and this understanding. So not just within our clinicians in terms of their understanding of what CPR means and entails, and that has positives or negatives in terms of whether they see it as broad and thinking if we're not doing it, that excludes a whole lot of treatment, which by definition actually maybe it doesn't. But also we have the flip side of that in terms of our community's understanding of what this means and what happens. And I think, Sammy, you're incredibly right. My work out and working alongside people developing their advanced care plans, talking about what matters to them at the end of their life, I'd often be working with patients and whānau family who were very aware that this person was on a palliative trajectory. They understood that. They were really clear about what they would like in that process of dying, what things would be important, who they might like to have, where they'd like to be. And then suddenly they say, oh, but I do want CPR, which was completely at odds to everything else that they just told us. And having a whole lot of people jumping on your chest, doing chest compressions and putting tubes down your throat to help you breathe is not what they were describing in terms of, I want my family at my bedside, I want people with me, I want it to be calm and quiet. So there's this sort of difference. And a lot of it, I think, comes from a lot of the understanding our community has about what CPR is, or the term resuscitation that we hear used, which is the broader term, comes from TV, and what we see in the media represented is often very different than the clinical reality. So, it's very unlikely that someone's going to be sitting up drinking a cup of tea and chatting to their family half an hour after one of these events, but that is what we often see in the media. So people have the sense that that's what it is.
Yeah.
And I think the flip side of that, or the extension of that then, is when family are asked to, or the person themselves are asked to think about whether they would want CPR or not, as you say, as a choice, without a lot of consideration about what's happening with that particular individual's health and their journey and what CPR may be a bridge to, if it's a bridge to anything, they often feel that they've made a choice to let themselves die, which is actually not the situation, because where they are is ordinary dying. CPR is not going to make a difference, but there seems this burden that people then feel they're carrying. I made that choice. I did this, I've signed the dotted line about this. Whereas I think that's a lot of what the Better CPR Conversations work is around, is helping both clinicians and the community understand that this isn't a intervention that's necessarily a choice, and it doesn't mean if you say yes you're going to have it you'll survive, and if you say no you won't. This is about recognizing when it adds value and when it doesn't, and if it doesn't, helping people understand there's still a lot of other things we can do on that journey for them that actually may give them a much more I'm saying fulfilling, that's probably too big a term, but a death that might be more as they envisage, rather than a medical intervention happening in those last moments of their life.
And then in New Zealand, is it an opt-in or opt-out? Because here, after in Ontario, Canada, you have to opt out.
Yeah. If you're in a
Yeah.
hospital environment, it's assumed that you would have CPR unless there's been a medical decision or you have chosen with your advance directive that you do not want it.
Okay.
But Sammy, that's really interesting. So if you think about the history of CPR and if you think about the pioneers, James Jude, Guy Knickerbocker, and
Tammy
William
Pegg.
Cohen. That's very kind. Back in the 1960s, this was developed to assist clinicians generally with iatrogenic cardiac arrest. So cardiac arrest that has arisen because of a procedure. Generally, it started out in the operating theatre because of general anaesthesia. Something went wrong. The breathing tube wasn't inserted correctly, and there was a sudden, unexpected stoppage of the heart. You know, in my world, in the cath lab, where we do heart procedures, we have now this modern technology that's amazing. But back in the 1960s, to take a heart X-ray, an angiogram as we call it, they used to arrest the heart with medication. They used to stop it and then take a plain X-ray film, just like you would just a chest X-ray film. And so that was a real anxiety provoking moment for most clinicians. So CPR in that situation was a wonderful thing to bridge them to the treatment to restore it. But modern hospitals are actually very different. Our cardiac arrest rates during general anesthesia have plummeted just because of advanced monitoring, better techniques. But in my world as well, in cardiology, you know, as a junior doctor 20 years ago, I would administer medications to treat heart attacks. And I would literally sit by the bedside as a registrar having a coffee, waiting for them to die because I knew that they were going to have a sudden change in their heart rhythm. And in the last 20 years, we now don't give these medications anymore. We streamline these people straight through to the operating suite and we restore their blood flow immediately. And we don't see sudden cardiac arrest anymore. And so I can't think of a situation in the last, 3-4 years where I've actually used CPR as a cardiologist, as a heart doctor, but the public perception is that this is a really valuable technique in hospitals. And by saying that they don't want it when they're offered it, they think that they're being denied a useful treatment. And I tried to promote the concept that sudden cardiac arrest anymore, because treatments are so much better for heart disease and operations, actually not very common.
I mean, I want to connect what you're saying to what you talked about earlier, a little bit about this ordinary dying. And it's really progressive, life-limiting illnesses that are causing people to die. And, you know, heart stopping or slowing down is a piece of that. And so why do you think that it's so hard to talk about? I mean, I know there's the public piece and there's the provider piece. So maybe the public piece, I'll ask Jane first, is like, why do you think that the public have this challenge about talking about this, and what can be done through the work that you've been doing in your national work?
I would say that there is a continuum when it comes to this discussion. As we'd say in New Zealand, a kōrero, a conversation. There are definitely some people that are very open to this discussion and prepared to talk about it and are quite willing to look at the fact that there is going to be some mortality in their future and what that might look like and how they might like it to be. And then at the other end of that continuum, there's people that are never going to die and it's not going to happen to them and they don't want to go there and have that discussion. And the complexity is on that continuum, we also sometimes have people that are quite willing to talk about it, but their family members may find that very challenging and distressing at the thought of losing that person they love, and they don't want to go there. So people navigate this really complex environment when they often want to have these discussions and conversations. So a lot of the work we do as the National Advanced Care Planning Program and the work that's done by our teams across the country is raising awareness around what advanced care planning is, and that this is thinking about the things that matter to you, what is most important to me, and if time was short, what would be the things I'd want people to know are important to me, and maybe it would be specifying some treatments that I would or would not want. In the New Zealand context, we have moved more towards gathering people's values and preferences and what matters to them more than a tick box list of different treatments, because there's complexity that often things they may have said yes or no to may not be the things that they actually are requiring or needing at that time. And so if we here understand more about what good quality of life looks like to them, what poor quality of life means to them, what wouldn't be okay for them, what are the things that matter most, that then gives clinicians, I guess, a whole lot of information that they can use their best clinical judgment to be aligning what they know as experts in that person's disease trajectory and an understanding of what's happening in their body at that point with the things that matter to them. And then we can make treatment alignment. And I guess that's a lot of what the shared goals of care work that we're doing and introducing to all our acute hospitals across the country, as well as increasingly into a number of our aged residential care facilities. It's taking it away from just being a decision about whether we do CPR or whether we do certain treatments, and it's encouraging clinicians to be having a discussion first about who that person is and what matters. We use the Serious Illness Conversation Guide as a framework to give clinicians some tools to navigate that discussion well and learn more about that person and the things that are of value to them. And then we align that with what we know medically is happening for them and what is likely to happen in the future. And that gives us, I guess, a better sense of the bigger picture. And it also means that if things come up unexpectedly from a medical perspective, a clinical perspective, things that we may not have foreseen, we still have some understanding and leverage that we can work off and use that to help direct the decisions we're making clinically. And I think the sort of idea, I guess, of a lot of our work is getting people to do that thinking in advance. Some people will choose to document that in their advanced care plan, in that there might be some specifics about treatments they do or don't want, but the majority of it is about who I am, what's important to me, how I like to make decisions, who I want involved in those decisions, what would be the things that would be important to me in those final weeks, days, hours. And then if they've done some of that thinking, or they've documented some of that already, when they come into that acute environment, to a hospital admission, and someone starts exploring some of this and thinking about what we need to do for shared goals of care, they've had some of that preparatory thinking, which makes it less confronting to have that discussion. Vice versa, if someone's first discussion is in hospital with shared goals of care, we're hoping that the way we are asking clinicians to position this is as kind and as respectful and provides that opportunity, and it then may stimulate someone to go away and think a little bit more about this, so that next time they come in, they've got a better understanding of the things that matter and help navigate that conversation. So I guess I always think about advanced care planning as a process and that journey, and it builds on itself. Each conversation you have, each thought, each discussion is growing that understanding of where you are, what happens, and it will shift and change over time as your circumstances change and your conditions change and things around you and your family might change. And that's part of that evolution. And that's why these discussions need to be ongoing, both personally with the people you love, but also with the clinicians that are caring for you at different points in that journey.
I think that's a really good point, Jane, about the fact that it is a journey, advanced care planning, right? It's not one conversation and it's not a moment in time. It's meant to be revisited over a lifetime as you learn and understand yourself better and better, or things change about what you value, what's most important to you, what you're willing to trade off. These are not static things. It's not our one mission in life that never changes. Advanced care planning is sort of like a meditation practice. You should just like revisit it or mindfulness over time. And Sienna and I are really appreciating that. I think we've reduced advanced care planning to be very much linked to future decision making, when we believe that advanced care planning, knowing yourself so well, can actually be a safeguard for individual patients and families to be seen as unique people, not just another cog in the wheel. You should know me, clinician, on a level that is beyond just being an organ. because I'm a person in an ecosystem of my family. And I'm going to tell you about me every time I see you so that I remain intact. And you and I have a relational experience. So we're thinking of advanced care planning as actually a very strong tool for patients and families to hold on to their personhood and to know who they are, and to also invite their healthcare providers every time they see them to know this stuff about them so they can have like a person to person relationship instead of transactional and, working towards decisions in the future and blah, 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 blah. What do you think of that, folks?
Well,
Yeah,
yeah.
absolutely. I was just going to
So
say that's, I guess, the concept of our shared goals of care. That's exactly what that's about, is each time that person has an interaction with the system, instead of it just being a yes or no to CPR, that clinician is tasked with having a discussion, understanding what matters to that person at this submission. So we talk about shared goals of care as targeted advanced care planning for an admission or an episode of care, because it may change, as you say, not just the evolution, but your condition may still be progressing. But we've seen situations, for example, where someone's come in and they've a great example was a patient I had a few years ago, respiratory patient. She had a lot of chronic lung disease. Her condition was deteriorating. She knew it was, and time was becoming shorter and shorter. The clinicians had long conversations with her about this. She'd had discussions with the palliative care teams, and she decided she was going to organize herself a living wake. She was going to have this big party to celebrate her life before she went. A week before this big party that had been arranged, she ended up back in hospital, unwell. And the clinicians recognized that this party was coming up, and they said to her, hey, listen, we've got something, we know that this is important. We're going to do all we can to get you out. So her treatment was actually more aggressive during that admission than it had been beforehand, and was again afterwards, because this was really important to her. She wanted to be there. She wanted to be part of this. She'd spent a lot of energy and investment and was really looking forward to it. So that particular admission needed different interventions because she was an individual. This wasn't just we're up to this point in her disease trajectory. This is her as an individual. This matters. Let's put a bit more treatment in. Let's boost up those steroids. Let's get her feeling well so she can enjoy this event, which she did. And then subsequently, future admissions, she wasn't so aggressively managed because she didn't want to be, because she knew that she was in those final stages.
Tammy, what were you, the clinician perspective of this is so important because, my sense is that clinicians too can have moral distress about seeing the suffering that is happening. And yet, and there's such a benefit to having these discussions early, but I think it's also very hard to find the time to have the skills to engage and have the comfort. So, what is your perspective of the challenges that clinicians face or cardiologists face to talk about ordinary dying and the progression that is happening, not just about end of life and death, but really the storyline of where they're at?
I think there's a couple of things just to build on what we've said just right now. I think there's a problem with our medical decision making model in that we have a culture around informed decision making, which assumes that all a person needs to make a good decision is the access to good information. But we know that decision making is much more than information. Decision making is emotional. Decision making is based upon your life experience, your goals, your wishes, your dreams, your priorities. And so our culture around informed decision making, where we give people information about CPR or any other treatment, and then we ask them what they want, seeps in through the bedrock of the culture of the practice of medicine. And then we have evolved this concept to shared decision making. And I think a lot of clinicians don't actually understand what shared decision making is. They think that shared decision making is just presenting people with an a la carte menu of options and asking them what they want. And that is not shared decision making, because that doesn't reflect our professionalism as healthcare workers to make a recommendation. And in that process, we also need to recognize that people are experts in themselves as well. So
Yes.
by evolving the culture of shared decision making, where we understand somebody's personal goals and priorities, we combine that with medically relevant information, and based upon somebody's goals and priorities, we then, as the experts in health, recommend a treatment that then best delivers those goals and priorities. Is obviously what we're talking about here in this process. But I don't think that surgeons, anaesthetists, orthopedic surgeons, hospital care doctors understand that subtle difference and don't have the tools in their kit to rapidly define what matters to somebody. And that's a lot of the work that we're doing around promotion of the serious illness conversation guide training to rapidly establish what somebody's fears, worries, goals, and priorities are. I think the other piece with clinicians is though the loss of the expert status in recognizing that somebody is their illness is progressing towards ordinary or natural dying. Because in acknowledging that progression of that illness, there is an acknowledgement that somehow we are failing. And that sits uncomfortably with clinicians who haven't yet learned to accept natural or ordinary dying as a part of their own practice. Because our systems, our medical schools do not enforce that in our training or in our culture. I think if there was a blood test for natural dying, just a simple test, I think we would discuss it a lot more easily. I can just see it now. I'm sorry, Mrs. Smith, the blood test has come back and your markers for ordinary dying are very positive. And we think based upon this, you have X hours, days, weeks to live. But in this process, we have to accept uncertainty for the future, and clinicians don't like that.
I just wrote that down. Markers for ordinary dying.
Love that. Yeah. I mean, you may be aware, like, I mean, our whole revolution, this waiting room revolution is about trying to go upstream, empower patients and families, and have them learn skills so that they can bring themselves forward. And of course, there's a role for training providers, but we also think, the most invested are patients and families. So I am curious, maybe Tammy, about do you see how do you talk about, do you have the opportunity, do you meet people early in their illness and have an opportunity to talk about what we call the storyline of an illness when we're zooming out, that there's a beginning, a middle, a late, and end stage, and to help to invite people early on to know that there are different chapters and what these different chapters might look like, so that they're not holding it all in and thinking about this only when they're in their late stage. Then we think about advanced care planning or what's important. No, actually, what's important to you should be brought forward in every decision. So I'm just curious, and we've talked to a few cardiologists, but I'm just curious how you talk about the different. Do you even talk about the big picture, the storyline, and what do you share for what people should prepare for over these stages?
Yeah, so when I read your book, I was sort of going, yeah, I love that zooming out. If I can go back, so when I took some time out and did a sabbatical project, we were working on some e-learning modules for clinicians to teach clinicians how to talk about CPR. And in that piece, there was a decision that we needed a leaflet for patients. And so part of the project was to consumer co-design some leaflets about CPR. And the funnest thing about this is I think any clinician should do a co-design project with consumers, because it's a really humbling experience. One of the things that really came out from the consumers very loud and clear is that they did not want CPR, death and dying, to be mentioned in a leaflet that could be given to them. They wanted their clinicians to talk about this in a holistic human fashion with empathy and kindness. And so it was suggested that we should design, Catherine Mannix, actually, who I know you've had on the podcast, who has been supporting us in Aotearoa for some time on this work, suggested that we should get the patients to co-design some questions to help them understand. which we did. And the questions very much align with what you're trying to promote in the waiting room revolution. They're very simple. What is happening to me? What is likely to happen to me next? If things don't go well, what are my options? And what will that mean for me and my family now and in the future? And it's just so simple. It allows people to understand actually where they're at with their health, what's going on for them right now, and what are their chances of sudden cardiac arrest versus progressive deterioration towards anticipatory dying. If things don't go well, giving that person an understanding of what actually their options are to make sure that they have access to healthcare treatments that may be valuable to them on their healthcare journey, but also then to understand the impact of those treatments in the short and the long term to make sure that they have a voice in making sure that those treatments align with their goals and priorities. And so the piece that we're currently working on is around empowering patients to participate as an equal partner in these discussions.
Yes. Clapping.
Yeah, that's exactly what we're trying to do. And is that so, it's so interesting because you're talking about we've talked a lot about CPR, but actually but it's so connected to advanced care planning. And so what you just talked about, I think sounded like this is part of the campaign. And we had a poster campaign here in Canada where we worked with Health Canada and they printed out, 3 questions you should ask, every patient should ask their doctor kind of thing. And it's very similar to some of the questions you talked about. But
Nealon who asked permission for the health camp. Was that Australia?
it was Tasmania, yeah.
Tasmania, sorry.
Yeah. Well, they're close by, but not the same.
Okay.
But
My parents.
but maybe Jane, so like what have been some of the results of these kinds of campaigns and some of this, I guess, empowering the public to take ownership? Has that been a result of the work, or has it, how are we measuring success, I guess, is one of the questions.
Yeah, great question. And I guess that's always a bit of a complexity with some of this, like management or organizations would like some really lovely sort of measures and figures to be able to tick boxes to say we've achieved it, we've not. And this is bigger than that. And there's so much that comes into it. I guess for us, we often are looking at some of the patient satisfaction surveys, some of their census. We've got a national survey that is offered to a number of our patients across the country every year. And there's a question in there around how heard did you feel by your clinicians? Did it feel like people asked you questions about what mattered to you? So they are some of the things that we look at to sort of see, are we making a difference and are we changing? And I guess the consumers have taken to this really well, the concepts of having that ability to have some power, but it's challenging. And we also need the flip side of that, which is the work we are hoping to sort of be able to progress again soon, is around the education for the clinicians, because I guess it has to be symbolic in terms of how it's developed. The last thing you want is, consumers being beautifully empowered, feeling strong and capable and coming with these questions, and then having clinicians that are a bit, don't know how to answer that, don't want to go there, not going to. So the work that we're trying to do now, before we widely release this sort of pamphlet that we've developed and get it out across the country more widely, is to be making sure that clinicians know about it and have some of the skills to respond empathetically and appropriately to those questions, and recognize that this is an opening for those discussions that they're needing to have, rather than seeing it as an affront or something that's difficult. So it's got to have sort of both sides of that to be working well. And that's the work that we're sort of in the process of progressing at the moment, to make sure that, we have some good impacts, and that it is a partnership rather than a one-sided approach.
Sounds like we're on like a similar trajectory, what you guys are working on, and same with what we're working on, because at the beginning we too focused like almost exclusively on the public, patients and families. But I guess there was part of us that thought, oh, we'll never be successful. But it turned out that people were engaging with our content. And there was at some point we said to ourselves, oh boy, this is not going to be good. We are going to unleash a new type of patient and family onto a system that is unexpected and hasn't changed. And so our, second act has been lapping back and trying to make sure that healthcare providers are prepared for the kind of new, respectfully activated patient and family that they're going to be meeting, hopefully, if we're successful. Um, and not only prepared for the questions that they bring, but also to learn how to invite them into these discussions if patients aren't. So, yeah, we have to go about it both at both sides, right? Both sides of the equation, the patients and families, the consumers, and the healthcare providers. And now forget about the systems planners. I mean, we got to get the healthcare systems planners and administrators in there too, right? But first, we can only do so much, right? We can only do so much.
Slowly, we sort of, the building blocks. And I guess we talk about making sure that we are aligning those blocks fairly evenly as we go through. Really
Yeah.
interestingly, you say that, Sammy, because in the very early days of the National Advanced Care Planning work, a lot of the energy and effort actually went into advanced communication training, giving clinicians the skills and confidence to have any kind of discussion with a patient, because we recognized it was really difficult to engage in advanced care planning discussions if you didn't have the confidence to navigate some of the complexities. And a lot of our clinicians didn't feel they had those skills or hadn't had the opportunity to develop that. So as things have changed and evolved, we've become a bit more refined, I guess, in terms of, and a bit more targeted and focused on how we do it with the serious illness conversation guide framework. And a lot of that comes from how, wanting to be able to offer this to more clinicians rather than just a select few, to make it more prevalent across our country and give that opportunity to more. But that's the nub of it, isn't it? It's like, it's great to have empowered people, but we need clinicians that are going to respond appropriately as well, and then know what to do with what they hear. That's that next step as well. How then do I take this discussion I've had? How do I document or record this or capture this somewhere that's meaningful to my colleagues and the system, and is going to provide that context to future discussions or future decision making? And I guess that's what we hope that some of the shared goals of care approaches are doing. It's giving people that opportunity to not just have this discussion, think about that particular episode, but then make sure that that's logged within our system, so that on the next admission we can go back and reflect not so much on the decision, but on the discussion and what mattered to that person then and where that's up to now, so we can build on that going forward.
When you think about it, can you believe how much time and effort and resources and people it is taking to sort of break down what we've built in the healthcare system, really? Like our confidence in always surviving things, or, the sophistication of the medical interventions and things like that, that there is this side that we're talking about that is really trying to, it feels countercultural almost, that we have to make clinicians, patients, and families aware that, what am I trying to,
I
I'm
guess
told that how much effort is going into now unbuilding
Yeah.
a
How complicated it's become when really
kingdom
it
of
should be so simple to
healthcare.
ask questions
Yeah.
of, what's happening to me? What will happen next? How can I prepare? How does this affect my family? I mean, you would think it's so basic, but in fact, it's very complicated with the machines and the processes and the guidelines and the drugs and the side effects and
The thing
tests.
that I'm saying is that it's crazy that because of all of that, we now have to go back and teach people how to say, you know, hello,
Yeah.
I'm a person.
Yeah.
Don't forget me,
Yeah. Yeah.
and I have people in my life, and you can be all fancy with your interventions and everything. It's just so, I don't know, there's something bothering me right now. I'll figure it out. Don't worry. By the end of
But
this podcast, but
But can I
it's
just go back because I feel like Tammy, I let you off the hook a bit, and you can if it's not a fair question, let me know. But I do think we've talked to some cardiologists, and there's really great medications, and and they we'll talk about people who stay on these meds and that, but I feel like they kind of skirt the idea of where is a patient at and what does heart failure look like over time? And maybe not so much late stage to end of life, because that's sort of talking about the dying part, but more in the middle, like from early to mid or middle to late. Like, how do you coach your patients, or do you have the opportunity to coach your patients through what they can prepare for? Like, how would you answer some of those questions that your patients have co-designed?
That's very provocative, Cian.
Sorry, I'm really putting you on the spot there.
Yeah.
But I feel like with all your background, you're the perfect person to ask for that.
In fact, Tammy said
Often.
just she messaged me the other day to say, had a great day, saw a patient. My junior doctors recognized how the conversations I've had with them previously made this conversation much easier. So, shared goals of care in action, these discussions happening. And yeah, it's one of those wins, isn't it, Tammy, when it happens?
Yeah, it was really true actually. Heart failure's changed. The four pillars of heart failure modern management has really revolutionized heart failure management. So when I started out 20 years ago, heart failure was a serious life-limiting diagnosis. In the modern world, actually, it's much the trajectory is a lot less clear. It's a lot. You can have an initiation phase, and then you can have a very, very long plateau phase where you're very well limited. Maybe life is not as it was previously. And that's one of the things I really like about serious illness conversation that carrying Ariadne Labs, because it really introduced this concept to me of offering a comment around somebody's function to give them some sort of prognostic statement. So I have a lot of people who feel, better on the heart failure medications, but not as good as they did previously. And so that's one of the first things I like to pull out is, this is good. We're never going to get you back to where you were, but this is better than where you were. And for me, that's really important to do as part of them understanding of the role of medications, because they often want to come off them because they feel tired, but you have to just explain this is your new normal.
Mhm.
Because that plateau phase now can be decades, almost like HIV, it's really difficult in that stage when I'm seeing them intensely at the start of treatment to talk about the transition phase as they move out of the sort of plateau years into towards anticipatory dying. And so I tend to see them, discharge them, and then see them again. And sometimes those first conversations that I had at the beginning, which I document beautifully in my clinical letters, come back and pay me dividends when I meet them again, sort of as in that case 4 years later. So I was able to say, hey, look, we met. You said that these things were important to you. You said that you were fearful about the impacts on your wife or family. Tell me about that. And it was, for me, it was a real time saving in that investment I had made 4 years ago paid dividends. I had immediately a relationship built with that patient again. I was able to pick up very quickly and move the conversation through towards the conversation around death and dying. Sadly, because of the continuity of healthcare, that sort of journey with a single clinician over somebody's life disease course is not the standard anymore. But still, I think that those values and goals and preferences captured can enable any clinician to pick them up. That they just have to accept that this is something they're not used to doing, and this
Hmm.
is just, and it takes them away from that vulnerability about losing their expert status again, is bringing those patient values in.
Mhm. Mhm.
Yeah. So I think I heard you talk about how it progresses, and in each sort of phase or step or at different bus stops along the way, there'll be different medication changes, but you will feel, better, but not as well as you were before. And so right from the start, there is clarity that this is a journey, and it's sort of a progression. It's progressive and not sort of a cure. These medications are not a cure for this. It's sort of we're managing it until, and what that looks like. I think that's, um, I think that's very clear, but also, it's so important because it can make such a difference to the understanding for the patients, but the families too, right? The expectations of what they're signing up for, and how this is where it connects to the CPR of what is the value of some of these interventions that they're having. Yeah. We're sort of we're sort of running out of time. I don't know if there was a question or a topic. Did we get to you fully explaining the Better CPR project? I mean, we've learned a lot about all the amazing things you've been doing, what's the national program, some of the things that are coming up. Is there something that you're looking forward to and hopeful for, or a question that we didn't ask you that you wanted to mention? Go ahead, Tammy.
I mean, suppose I'm just trying to get this message out to any audience that is willing to listen. And I really want to promote the history of this technique that has undoubtedly changed, hundreds of thousands of lives over the last 70 years, but for people to understand its value and purpose and to understand the history, because only when we understand the history can we understand where it should go and the natural evolution to this technique. I think it has magical properties in the hearts and minds of consumers and clinicians. And I'd like to sort of dust off some of the myths around it and really go back to understanding what it is. I've written a book and I'm just working through the processes of trying to get that published. I know how difficult this is, and I know that you know how difficult this is as well. So if there are any publishers who are interested in reading a manuscript, I'd be more than happy to share.
Mm-hmm.
What is the draft?
We have someone you can speak
to. Yeah.
Thank you.
What's the draft title, or what would it's going to coming out soon, hopefully. Do you have a title?
Well, there's been a couple. We've gone through, Live Once, Anything But CPR. We're now currently kind of figuring more around Stand Clear, Anything But CPR. But again, suggestions from your listeners would be most grateful.
Wonderful.
And Jane, how about you? What are you looking forward to and hopeful for?
I guess our New Zealand health system is going through quite an evolution at the moment. I guess like lots of the world, there's a lot of sort of shake-ups and moves and changes. So we're in a very interesting space at the moment. So I'm looking forward to a settling of some of that. So there's more scope and opportunity for us to progress some of this work. At the moment, some of it's needed to be held while we kind of re-establish where we sit within the system and what our funding mechanisms are. We've changed organisations in terms of the national program. So we're really looking forward to an opportunity to sort of further expand and to progress this work. And I think we're starting to see it infiltrating all sorts of our legislation, our policies, our processes, and it's just about making sure that we have that opportunity to be really putting the resource behind it to give people that opportunity to have their voice, to be the experts on themselves, but then have our clinicians with the skills and compassion to be able to hear that, take that on board and use their clinical skills to align that with what treatment is appropriate to be offering in those situations. So I think there's, it is a huge culture shift. It's a really big step for people to take. It's, as you say, Sammy, it's swinging stuff around so much from where we've kind of got to. And it is tough. And we see that with our audits of our shared goals of care, consistently, lots of our hospitals are doing a great job of making a choice in terms of which goal of care the person fits under. But when we look at how well they've documented anything around the discussion that's happened, it's not so effectively done. So really focusing on getting people to recognise, as you say, the value that conversation has, the dividends it will pay down the track, as Tammy talks about. And I guess encouraging our role models across our organisations, people like Tammy that are out there promoting, doing, showing by example, giving people those good experiences, providing efficiencies for the systems and really recognising what this contributes to the greater good of what we're doing, not just because it's good for our systems, but most importantly, because it's good for the people. It makes a difference on people's journeys, their families' journeys, and it makes a difference for the clinicians that are having that engagement as well.
Yeah.
Love it.
Tammy, Jane, thank you so much for joining us today.
Thank you.
Thank you.
Thanks for listening. Our workbook, Applying the 7 Keys for Navigating a Life-Changing Diagnosis, is available now at all online bookstores. Visit our website for more details and to access our free resources, event listings, and learn all about our movement. The best way to keep up with us and our work is to join our newsletter list, or better yet, become an ambassador. This episode was produced by Maggie Sivak, myself, Kayla McMillan, Shilpa Jyothi Kumar, Bethany Bachanfuso, and Kathleen Bartlett. Our theme music is Maypole by Ketsa.